Hello, everyone. Welcome to another episode of Perspectives in Professional Psychology. I'm Dr. Lance Garrison, Dean for the College of Professional Psychology at the Chicago School. And today, we're going to step into a conversation that I think is deeply essential. Unfortunately, it's often avoided, but it's deeply relevant to the well-being of the clients that we work with as psychologists. And these are the areas of sexuality, identity, and how clinicians engage these topics while in practice. Now, despite the profound role that sexuality and identity play in mental health, many clinicians still hesitate to initiate these discussions, whether it's discomfort or a lack of training or a fear of misstepping or assumptions about what's appropriate. These gaps, unfortunately, can leave clients feeling unseen in some of the most fundamental aspects of who they are. So, to help us unpack this, I am honored to be joined by someone who has devoted a lot of his career to expanding access to culturally competent, sexually affirming care, Dr. Braden Berkey. Dr. Berkey is a licensed clinical psychologist whose work spans private practice, university counseling, community health, and managed care. He's focused extensively on sexual minority health and sexual well-being, previously serving as the Director of Behavioral Health and Social Services at Howard Brown Health. He also created the Sexual Orientation and Gender Identity Institute at the Center on Halsted, helping build a pipeline of clinicians trained to work competently and compassionately with the LGBTQ plus communities. His consultation work with the University of Chicago's Department of Medicine and numerous HIV/AIDS organizations has influenced care models across the region. Since 2008, Dr. Berkey has been with the Chicago School as an associate professor, in our PsyD clinical psychology program in Chicago, where he teaches professional ethics, clinical practice, diversity, and human sexuality. He is a certified sexuality educator through AASECT, the executive director of projects advancing sexual diversity, and has directed the multiplicity of the Erotic Conference. Tonight, we're going to spend some time exploring why these conversations are so difficult for clinicians, how we can do more to create therapeutic spaces that allow clients to bring their full identities into the room, and how training programs can better prepare future psychologists to engage these topics with confidence, with nuance, and with humility. Dr. Berkey, thank you so much for joining us this evening.
I always welcome any opportunity to talk about this.
So, as I was kind of laying out, as I was describing your bio, you spent a lot of time, a lot of your career on these issues of sexuality and identity. And I'm wondering if you could talk to us a little bit about how to help clinicians develop comfort and competence in this area. I mean, from your experience, what do you think makes these topics so hard for clinicians to initiate in practice?
I think that they're difficult to broach for the same reason they're difficult for anyone to talk about. They're loaded with values, they're politicized, they're marginalized, they're pathologized. And when people in your profession come with all of the same misperceptions and misinformation that the general public has. And then they get into our programs and, just to be very candid, we don't do a good job of correcting any of that. My group, Project Advancing Sexual Diversity, did a study in 2021 of 235 APA accredited doctoral programs across 52 states. Only 20 of them offer a human sexuality class, and only 3 of them require a human sexuality class. So you can get your doctorate. There's nowhere else to go after that, right? That's why I tell students,
Right.
that's why it's hard. There's nowhere else to go. And know nothing about human sexuality. So you mentioned competence. Competence is built on 3 things: knowledge, skills, and attitudes. So our students don't get the knowledge. We don't talk about it. They don't get the skills. Where we get skills is on our practicum sites and in our internships. And in another study, 2018, I think, with 185 PsyD students in our program across all cohorts, We looked at their comfort with sexuality, and they all rated talking about sexuality as one of the lowest things they're comfortable with. And the sad part is, as they went through the program, as they advanced their program, their comfort with talking about sexuality went down. It didn't go up.
Wow.
So looking at that deeper, in some subsequent work, looked at that, and we're getting quotes from students about, like, they're being actually told at practicum they shouldn't be discussing sex with their clients. One in particular, I remember, is a student I knew who said she was working with like adolescent boys in a detention center, really marginalized guys who had no sex ed whatsoever. And some of her clients at 15 had several children. So obviously there was a screaming need for sex education in there. And she was talking to her clients in a very appropriate, professional, empirically based kind of way. And when she went to her supervisor and said they were processing this stuff, he told her to stop. There's something wrong with this, where people can't get their skills. Uh, the biggest issue for me, and where I start out with any sexuality training, is on attitudes, because you can't get knowledge if you don't address the attitudes. If people come into this and they've kind of like, I've got my belief system, I know how things are, I'm not open to hearing other things, they will not take in knowledge. And if they don't have the knowledge, they can't go and build the skills. So we have a lot of work cut out for us.
Yeah, it's fascinating. I was just saying about my program. We didn't, my doctoral program didn't have a single course in human sexuality. And you're describing this gap in competence, not just for students going through the majority of programs right now, but generations of psychologists.
Yes.
Which is quite stunning, right? And for something that is kind of so fundamental to the human experience, it's a gap that's kind of hard to reconcile when it comes to the field.
It is, but then the field reflects society. And so sometimes I like to think society pulls us ahead a little bit, and sometimes we pull society ahead a little bit. But yeah, when we did this study about looking at students and were they competent, and again, looking at knowledge, skills, and attitudes with them, and they weren't, the next study was, then why weren't they competent? So then we went and looked at faculty in APA-approved programs, licensed clinical faculty, PhD, PsyD programs didn't matter, and found out that they rated themselves much higher on what their knowledge was than when we actually measured it. And also their attitudes were that, yes, sex is very important and we should be addressing it. I'm not going to address it, though. I'm not going to.
Someone else can do that.
Someone else can do. That's always the issue. I did a presentation at a interdisciplinary conference, and it's called "Sex, the Hot Potato of Interdisciplinary Practice," because everybody says someone else will do it. Try to talk to your physician, they'll say, go talk to the nurse. Nurse will say, go talk to the, your OB-GYN, go talk to your shrink. Nobody wants to really address this because no one feels competent to do any of this. So when we looked at, like, why weren't the students competent, we looked at faculty. No surprise, we found they weren't competent either. They had no training. And same as your experience in my doctoral training, never had a course on human sexuality at all. It was never addressed in my training or practicum work at no point. And to your other point, that it's so central, it's central to relationships, it's central to lifespan development, it's central to quality of life and healthcare. And so it's not in this isolated thing where everyone wants to kind of put it in this little, sealed box and go, well, that's sex, we don't want to talk about that. What does that have to do with what we're addressing? And when I started 18 years ago in our program, I started this project Advancing Sexual Diversity, which is where I run all my dissertation work through there and engage the community through that. And in the doctoral level, if someone mentioned penis or clitoris or vagina in a class, giggles in a doctoral class. And so over those 18 years and working with the students who are devoted to this as well, we've gotten this integrated into our biobases class and into our relational classes and our lifespan classes. Now we're talking about human sexuality in all those classes now in our program. but it's been like a continual effort to work with faculty and for my students to sort of be confederates in the classroom and raise their hand and say, well, what about this? And what about that? And kind of pushing the faculty a little bit, but we've gotten there.
Yeah, I was thinking about a conversation I had in a previous episode, Dr. Berkey, where we were talking about the importance of, the really developing a strong self-reflective capacity, the kind of the deep introspection that a psychologist needs. And we talked about that in terms of, like, it's important to be able to hold up a mirror to yourself and really look deeply in that. That's a big part of the training with psychologists. When I think about this human sexuality piece, this image comes to mind of us asking students to hold up a mirror, but there's like a big spot in that mirror missing that's not getting reflected back.
Yeah.
It's just a big gap in the training. So I'm very happy to hear that it's a big part of our program.
It's certainly changed. And one of the things that this was a long project and we just launched it last year was our Office of Continuing Education does offer a human sexuality certificate program. There's 6 modules to it. I worked with people I know well. One of them is a graduate of our program to develop the curriculum. Dr. Hanslick is a graduate of our program. She's also an AASECT certified sex therapist and AASECT certified sex therapist supervisor. And so we put this training together because we realized people are not getting this in their graduate programs at all. And we thought there's a gap, and luckily there are more programs out there, but it's a very digestible certificate program. It's 6 modules across a year. And what I like about it's we've gotten our school credentialed by AASECT, which is the American Association of Sexuality Educators, Counselors, and Therapists. It's a mouthful, but the school is credentialed now to offer CE. So that was our first step. And if people take this, it's not an AASECT certification. That's much more involved. It involves supervision and actual clinical experience. But certificate is stackable, meaning you get, I forget how many credits through the course of that you could then apply to certification if you'd like to become a certified sex therapist or educator or counselor. And I tell my students, like, if you want to have a full private practice, everyone I know that's a certified sex therapist has waiting lists. Because people, the very thing we're talking about, people
Yeah.
in practice say, I don't deal with that. You need to talk to someone that's comfortable with it. And the part of that is when we studied and examined faculty, the thing they were comfortable with was psychopathology. They weren't and a lot of what I talk about in our human sexuality class and what our project Advancing Sexual Diversity tries to promote is sex is a natural part of life. It's a part that should be addressed through all parts of your lifespan from preschool, infancy, all the way into your 20s. It needs to be just talked about in a normative way, and that we need to integrate it into our classes. So it's very nice if we have the certificate program that people can do. We have an elective in our program, but it has to be talked about across all of them. That's the only way we'll get competencies. And the more students hear faculty and their supervisors talking about sex, not just in terms of a diagnosis, but in terms of lifespan development, in terms of someone getting pleasure. How is someone rating pleasure in their life? And we kind of like to think about as that's an additive, that's an extra thing. We're concerned about core well-being issues. Like I have a whole other presentation about how having good sex, it promotes health and life and aging. So, and I've done that for physicians. It's like you have it is not just this sort of like, well, it's nice if you have orgasms. Like, no, there's studies like the more orgasms you have, particularly with men, the longer your biological life is, not your chronological age, but your
Yeah.
biological age is healthier.
Yeah.
So these are very, very critical things.
Yeah. First of all, I'm thinking as you're talking, I need to take that certificate course.
Please
Office of
do. It's
Continuing
fun.
Education.
Yeah.
Yeah. You know, so there's this whole thing of clinician discomfort, and I think it's hard to argue, like you said, that there's an there's an there's an aspect to intimacy and sexuality that's core to being human, and but we have this discomfort, right? So you mentioned the discomfort of so many clinicians in broaching this area. How would you say that clinicians can kind of begin to separate their own discomfort with this topic and what clients actually need from the conversations that could or should be happening in a therapy context?
Well, first of all, is just to recognize that they don't know what they don't know. And the thing is, when we talk to clinicians, people will rate themselves much higher on their sexual knowledge than it actually is because we all think we know a lot about sex. We're in a culture that's saturated with sex, a lot of really horrible messages on sex, but we're saturated. We have our own experiences. We all have experiences with it. And so for people to let go of what they think is normal, so if I'm having sex 3 times a week, I may think that's normal. If someone else is having sex once a month, they'll say that's normal. Someone else having it every day, they'll say that's normal. They're carrying that into their clinical work. And so they're not thinking, wait a minute, would you do that with anything else as a clinician? Would you do that with anything else?
That's what I was just thinking.
But we don't. So it's for people say, you know what, I don't know what this is. I know what I think is normative. I know what my culture has integrated into me. I know my community standards, but I don't know what I don't know. And so to seek out supervision and training, I mean, I say this till I'm blue in the face, as clinicians of any kind of clinicians, we are lifelong learners. We have to be lifelong learners. I was talking about this yesterday. We had an admissions meeting, and I pointed at my shelf in my office and I said, I have 6 DSMs on my shelf, starting with the first one I in graduate school. There have been 6 versions of that since I started my journey professionally, and I had to learn over and over again. So for people not to be afraid, like to say, I don't know. I mean, to have some humility, say, I don't know these things. I've been operating on my own sort of baseline and think that's normative, and it's not. And because of that, we pathologize so many other things because we don't actually know the science or the research behind them.
Yeah. Yeah, I was just thinking about this kind of in the sphere of diversity. I mean, we have an ethical imperative to um, develop confidence in the
Mhm,
space of diversity and cultural humility. And again, it's like that hole in the mirror I was just talking about. This
mhm.
is an aspect of diversity that
Yep,
we're not kind of living up to the professional expectations on. And when I hear you say, and it makes sense. It kind of meshes with the experience that I've had. We're going into therapeutic context using our own kind of personal definition of what's normative from a sexual perspective, and then making assumptions, right?
yeah,
And bringing in our own potential misconceptions
mhm.
about sexuality. And in some ways, um, I mean, that could be potentially harmful to
It
therapeutic outcomes.
it's very harmful, and it's also it's harmful when people give out misinformation. It's also harmful when people completely avoid the topic, and if a client starts to broach it, and I talk about this in our interviewing class, you give signals, your micro nonverbals, you can shut somebody down real quick and let them know that is not something I'm going to talk about, right? Or you shift in your chair, not really, you don't say, oh yeah, let's talk more about that. You're doing this. They get the message not to talk about it. So I think the more, people, one year we always do a conference every year, Sexploration, and one year we always have an interactive display, and we had a video that was made by someone in our group knew to a film student, and they had a video of just people of all ages across the lifespan saying clitoris, penis, vulva, orgasm, like 5-year-olds up to great grannies, and we just kept playing that loop, and then we had a reaction board next to it, and seeing how people were like, "Oh, a 5-year-old said penis, like, that's what it's called." Um, but these were, our students across all our programs,
Yeah.
every program, and it was really they had to look at it and think, why am I uncomfortable saying this? Why is this so hard for me to use this language? And so, back to my, I always use this term. I learned it from some professor years ago, the three-legged stool: knowledge, skills, and attitudes for competencies. Like, we got to deal with the attitudes first. And the more that faculty just normalizes and just talk about as part of what we do, in our interviewing class, I make sure we practice in our class asking people one question during an initial interview. It's like, and the question can vary, but it's usually something along the lines like, how satisfied are you with your sex life? And often, clients will just go, it's okay. I don't need to talk about it. And I say, that's fine. It's fine. It's the important thing is that you asked it. Because when you ask that and you asked it and you really have to get comfortable with this and you really have to do your own work and you have to be able to ask that the same way, like, tell me about your depression, say, tell me about that, even if they don't want to talk about an intake, and most people don't want to, you know, be that open right up front. You
Right.
gave them the message that this is the place, and I am the person that you can talk to about these things.
Yeah, I think it kind of touches on where I wanted to go next, is that if you don't ask that question, you're not leaving open the possibility of having that discussion. You're sort of closing off a piece of that space because it can be really hard
Yeah.
for a patient client to bring that up independently. If you ask that question, even if they're not in a place at that moment where they are comfortable talking about it, you're at
Mhm.
least creating some initial space saying, hey, I, it's okay to talk about here. I'm asking about it.
Yeah.
And so let's talk a little bit about, okay, so let's say we can get that initial question out during an
Mhm.
interview.
Yeah.
What does an affirming space actually look like in day-to-day clinical work? I mean, from your perspective, what do you think helps clients feel safe enough to bring more of their full sexuality and identity into
Yeah.
the therapy space?
My first thought is the same as with everything. I really talk a lot in interviewing about how we build this foundation of rapport and respect and convey that we are competent to help them. And so it's the same thing. And sexuality just needs to be woven into that. But on a more on a very pragmatic level, and this is something I've talked about lots of different places, is the messaging you're giving your client starts before you ever say one word to them. What's on your website? We all, at this point, if you're running a practice or a clinic, you have a website. What is on your website? Is on your website, does it show different kinds of couples? Does it have diversity of all kinds on your website? When someone comes into your reception area, do they see art and things that reflect them? When they do their intake form, is there a place for them to check a box that is actually accurate for them? And then all these things, like, it's your interview, and we are all enculturated to think this way. But, often if we're doing an interview, we ask about relationships, and we'll say often, and we do this a lot with kids. She's like, "Oh, do you have a boyfriend? Do you have a girlfriend?" It's like, you just shut down the conversation for anyone that is not heterosexual and cisgendered. So instead of saying that, you really have to use, I think, creating that affirming environment is using gender neutral things and allowing people to know, oh, okay, maybe, again, building that trust takes time. But as you continually not gender things and continually leave this open for them to define themselves, that does it. Just looking at our signatures on our Zoom, I think it's very important. Like, I put my pronouns there. I don't have to. I'm privileged. I'm cisgendered. My gender is, I don't have any problems with that. But the fact that I always include those, and when I introduce myself to new students or new clients, it's always like, "Hi, I'm Dr. Berkey. I use he, him pronouns."
Yeah.
And the message it conveys is to people who don't use those is like, okay, I don't have to go out of my way and say, well, my pronouns are this. They say, oh, we actually just ask pronouns. And even if people are cisgendered and are in the majority, it gives a message to them that this is something we should do. We should be inclusive. And so there's lots of, there's not one big thing that you do that makes somebody feel like you're in an affirmative environment. It's
Mhm.
a lot of things. It's a lot of little things.
Yeah. It's part of that. I'm not sure if this is the right way to describe it, but like the overall kind of therapy milieu that you establish.
Yeah.
Like you said, your website, the office space, around
Receptionist,
in yeah, I mean it's just
you know,
these little things add up
all of them.
to try to create as much space for building comfort with this topic.
It's intentionality. It's going and it's the same thing with any of our diversity issues. The intentionality thing about like what it's like to walk in here and I will say, we really have to pay attention to that. When I was at Howard Brown, which is a largest LGBT healthcare facility in the Midwest. Our clinicians were very skilled at working with people across the gender spectrum. Our physicians were, but our receptionist, and we didn't know. We didn't know that people would come and they would keep misgendering them. They would hand the insurance card and it would say their birth name, which is often their dead name, which means they don't use it anymore. And they would just keep using it. And finally, I finally got feedback from my therapist saying, you need to go out and talk to, John. And so I said, what are you doing? And there was no malice there. It just had not been trained, was not, part of the whole gender community, did not think about any of that. And just to zigzag a little bit, thinking about that makes me go off on another thing, and which is this was a center that's for sexual and gender minority folks, and our receptionist was a gay identified cisgender man, and a lot of times we do this aggregating the LGBTQIA on and on and on at this point. And we have this idea that, well, if you're one of those letters, you get them all. No, you don't. And so here's someone that thought they were very well versed in working with the community, but came from a very, gay male perspective and didn't see why this was a problem. And so we can't ever assume people, have the right skills or knowledge. We always have
Yeah.
to be thinking about the whole environment. Have we trained everyone? And in a very respectful way, inviting them in, not shaming them if they got something wrong, inviting them in to think about, here's how we want our clients to feel, and this is how we do it.
Yeah, it's interesting and kind of leads me to another thing I wanted to ask you about that I think is important. Even at a place like you're talking about, this is the space to
Mhm.
provide this kind of support. Missteps happen.
Yeah.
And I think that that's one of the things that clinicians get worried about, right? They get worried
Yeah.
about making a misstep.
Yeah.
And to your point, there was no malice on John's part, right? Best of intentions, doing the best with what the training he had and what he thought the job was. We all get it wrong sometimes.
Yeah.
That's just the nature of, again, being human. We make mistakes, we misstep, we step in it
Yeah.
sometimes. When a clinician missteps or
Mhm.
unintentionally invalidates a client or the client's
Yeah.
experience, what does good repair look like in those moments?
Well, not just around sex or gender, but
Sure.
overall, it's the same answer. And I think, the first thing is what are you what intention is being conveyed? So if you make a misstep and it's truly just you just it's a flub or you just don't have the knowledge and you made a mistake, I think that's received differently than from people. Then I'll use a John example, so that he had no malice, didn't mean anything. I had a client that was a transgender woman in her 60s, and she was getting care at an HIV facility, getting her benefits and everything through there. And the people there intentionally kept calling her by her birth, sign gender birth, and her name that she didn't use because it was on all the form. And she had tried to correct them and it kept doing it. And it was intentional. You could tell there was an intention behind it. And that felt so different to her than if somebody else just kind of flubbed up.
Sure.
And so, how do you convey your intention? And then having the humility to say, "I'm sorry, I think I used the wrong pronoun," or I think or even to go back, after you listen to a tape or reflect on a session, go when they come back and say, "I want to check in with you. I think I made a mistake somewhere along the line. Take this for what it's worth, but my experience as a clinician and as a supervisor and as a program director is particularly with around the gender, people navigating gender, when we would mess up and if they knew you were trying, that you genuinely were seeing them and you used the wrong pronoun, they went, "Oh, it's okay, I get it." But if you apologize and just owned it and not dwell on it, not make it
Yeah.
but let them do that. And I talk when I talk about all this stuff, I want to acknowledge how hard this is for people that I think we are so hardwired for gender
Yeah.
that we are so enculturated that our brain when we meet new people, we automatically put them male or female. We automatically do it. I do it, and I've worked in this for 30 years, and it's like we do that all the time. And so I had a student, and she had a client who was coming into the center on Halstead, and this is like a 40-ish-year-old man came in, work boots, denim, flannel shirt, looked like a construction guy, scruffy. And after multiple sessions, he finally said, "I think I have concerns about my gender, and I think I always have." And so he asked her, he says, "Here," and this always gets me. He said, "At least here, could you use she and her pronouns? And I'll make up names." He said, "And can you call me Kathy when I'm here? It's the only place I get this." And so my student, you know, very affirming, very well trained in there. And what we processed in supervision was how she kept saying he. And what we talked about was, and this is why, I don't think we create change by shaming people or saying I have the higher ground, I know the right words and all that stuff. We have to invite people in. And what if you think about if you're working with people who are across the gender spectrum and presenting in many, many different ways, and here's someone who's clearly struggling with an identity, but living and having to live full time as a male for safety in his income. I came up with this thing that it's like the Stroop color test. When you look, you're looking at an image, and your brain is so wired to say that's male. It's male.
Yeah.
And you're trying to, when you look at the blue dot and it says red, and you say blue, but no, but it says red. It's that kind of thing. So I try to tell supervisees and students to have some grace with themselves
Yeah.
if they're messing up, but humility and intention, and then also give yourself grace to do that because it is hard to always, and you always have to ask people. You can't assume when somebody walks in the door what their pronouns are or what their identity is.
Yeah, that's a huge part of it, right? It is knowing that we are kind of wired, right? I mean, our brains use heuristic devices all the time to navigate the
Yeah.
world, to minimize the amount of processing we do. And so this is kind of part of that. And I this is what I believe and what I think I hear you saying, Dr. Berkey, is as as professional psychologists, we have to work hard not to fall into those heuristic traps. And sometimes they are traps. And if we do, we need to have enough humility and self-reflective capacity to own it, to have some grace for ourselves about it, because a lot of this is difficult to overcome
Yeah.
the programming in effect. And just own it,
Yeah.
apologize, work to be better, which we're all called to do as lifelong learners, and move forward.
And you mentioned something else, and that it's ongoing critical self-reflection. Where does this come from? Where do I challenge this? And none of us get through life without being inculcated with values. And
Mhm.
the gender one, I just it's so automatic. And what really when people can't read somebody, it triggers, I mean, an actual physiological response in them when they're like, I'm not sure, what this is. And then that it can be fear. It can be fear of looking bad and saying the wrong thing, but it can also be fear of someone who's different And somehow it's very threatening. Transgressing around gender is very threatening to people. And this is why we have so much violence towards particularly transgender women. And that's a whole other topic. But it is that hard wiring that kicks in with people about this does not compute. And then you ask the question, well, does not compute based on whose program and why does it have to compute? And why isn't there room for other ways of looking at things?
Yeah, and it kind of leads me to another question. Sexuality and identity are these important things that we too infrequently address. They don't exist in a vacuum, right? And I think one of the things you were just talking about is the culture, religion, intersectionality. They
Mhm.
complicate and they shape the therapeutic conversation. So I'm wondering if you could maybe kind of tie those
Yeah.
threads together a little bit for us.
Well, they do that for our clients and they do that for us.
Yes.
And so that's why we really have to very intentionally learn about this because it is this big hole in the mirror and it's this big hole in our education that we don't know what even normative is. We don't know what sex is. That's always, when I start usually any of these, it's like, what is sex? And it's usually fall into penis and vagina intercourse. That's the default. Maybe oral sex gets in there too, but it's like there's so many things that are sex or sexual or erotic, and those are things that are so worth exploring with people. And we think about the people we work with, thinking about intersection, like working with older people, working with people with disabilities. One of our students is working with women with spinal cord injuries around contraceptive and menstruation management. No one talks to them about this. So, just having that, being able to do that. But this intersecting part is the thing. 'Cause first, we have to deconstruct our own and examine it and see where that comes from. And I'm always really careful with students. Two things. One is, first thing I tell students when they start the program is you're joining a profession that has a set of values that takes positions. And you need to know that when you come into the profession while you can still get your money back. So if you're okay with that, good. So first you have to know that. And then you have to know that what my job as a professor is not to change your value system, but to have you examine it. And if people want to say, I still have these values, I'm like, okay, now you're aware of them. Now you're aware of where they came from. How does that fit with clinical practice then? What kind of settings are you going to practice in? Where are you going to encounter people? I love when people say, well, I don't need to think about people that are not straight or not cisgender. I'm not going to work with them. And I'm like, hate to tell you, I don't care if you work at Jewish Family Service or for fundamentalist faith-based practice, you're going to have these folks that are going to come in. And if you aren't able to create the space for them, you're going to, as we said earlier, do damage. So we have to do our own work and be able maybe to even compartmentalize and do some work around that, get supervision, look at that. But then we have to come in with very strong knowledge because there is so much misinformation that is so supported in the media. So then when we talk to people, we have to walk this line of respecting their culture and their values and then saying, and, maybe you do feel this way about your son or daughter's gender, you know, and then, and I very, very, very respectfully asking people, where does that come from? And I say, well, my religion. I said, okay, where do you get those messages within your faith? Where can you point to in your, the Bible, the Quran, the Torah that says this? Because actually, when you go back to the original source material, it's not quite so clear. And so I'm not challenging them to say, you got to change your values. I'm right. You're wrong. But then I can also say, well, I respect your values, but also here's what we know, from God, sexuality research. This really took off in the 70s. We got 50 years of research. Say, here's what we know. This is what we know about diversity in sexuality and diversity in gender. I have a couple books, one called Biological Exuberance. It's written by a zoologist. We see intersex, transgender, gay, bisexual, polyamorous animals and all across the animal kingdom. So when someone says that's just not natural, I'm like, okay, what tell me natural. And I'll say, because I can talk to them all about intersex deer and transgender clownfish and all these things. Say, this is natural. And as someone that started out as a biology major, I pretty quickly learned that things do not fall into two neat binaries.
Well, we're humans.
We're human.
We're natural.
Yeah.
And
Yeah.
so there's a multitude of expressions of humanity across
Yeah.
all of, and it gets hard because we like categories, right? We really like labels and we like categories, but the reality of the human experience is
Mhm.
it's not quite right they're quite the right way to say it, but it's all shades. I was going to say shades of gray, but it's just shades of
Yeah.
expression and color and culture and experience. And
Yeah.
there's so much, there's these discrete categories that we've developed, and there are reasons for them. From a research perspective, we've got to categorize things so that we can count
Mhm.
things and we can measure things. But in some respects, it's a little artificial at times, right? It's a little arbitrary, and
Mhm.
it doesn't really capture kind of the full expression of the human experience.
No, none of the categories do. I mean,
No.
your race doesn't capture everything. Certainly gender doesn't, orientation, any of those things. And what I talk about, because, there's sort of a developmental projection and diversity when we start talking about these things and people start going, "Oh no, I actually think like that. I
Mhm.
actually have these categories in him." Said, "Of course you do." Said, "When you get on the L in Chicago and you see 100 people, can you possibly try to figure out the permutations of each of those people?" This is how we navigate the world, is by categorizing and saying, this person is safe, this person isn't. Again, often misread, or this person is like me or not like me. And we're completely wrong. But there is a functional reason why we do these things. What we have to do is continually challenge ourselves, and as clinicians, and specifically, not bring those into our work.
Absolutely.
But I don't want people to feel like they're bad or they're somehow not
Yeah.
good people or good clinicians because they think like that. No, it's like, this is how we navigate the world. But when we're sitting in that room with somebody, we need to really let that go.
We have a calling and an obligation
Yeah.
to let.
And my other mantra is, we we are we are healthcare practitioners. So we are continuing to refine and learn and do better. So when it says I'm still not getting, it's like the fact that you're trying and you're working on it is
Yeah.
all I can ask of you. But we're practitioners. I never, ever, ever, ever get this. I tell my students in diversity class, in particular, it's like, I'm staying in front of this room because I am older than you and I have devoted, X number of years professionally to this and really looking at this clinically and looking at myself. And I said, and I still have blind spots and I'm still learning and I'm going to learn from you. I learn so much from my students every year about some other thing I just never had exposure to.
The real danger is when we find ourselves thinking that we don't have any more blind spots, that we've done all the work.
Yeah.
Yeah.
Yeah. I think the word expert is just a dangerous term.
I
I,
completely agree.
I
Completely
don't
agree.
like it. Yeah.
Well, as we come to the end of our time, Dr. Berkey, I want to close us out on something that's maybe a little more forward looking. So
Hmm.
after all of the advocacy and the clinical work that you've done over the years, what's giving you hope right now in the field?
That's hard. I'll answer it two ways. I just came back from the Society for the Scientific Study of Sexuality, Quad S conference that was in Philadelphia. It was a lot of good new information, a lot of good things to bring back, but also just a lot of concerns that
Mm.
the conference was not as well attended. There were people that weren't there to present because they were international and they were afraid to come into our country to present. There were people that should have been there that weren't there that have been defunded for their research. And that's chilling. I mean,
Yeah.
working with sex, and particularly when you get into the margins of sex, And then the more you look at the margins, the more you realize they aren't margins. So we've been talking about gender and sex in general, but also when we start talking about polyamory and BDSM and power play and all these other things, which by the way are not marginal. A study, I'll divert for a second. Justin Lee
Sure,
Miller
yeah.
at the Kinsey Institute, 4,000 people across this country, evenly divided, self-identified male and female. The most common fantasy people have is multi-partner sex. Only 5% of the people in 4,000 people never had that fantasy. Never. So 95% of people have fantasized about multi-partner sex at some point in their life or another. Now, if we know that as clinicians,
Yeah.
and people are talking about, I feel dirty, I feel abnormal, I do this. And I say, well, actually, 95% of people have that fantasy. It's very common. But whether they act on it or not, it's a very different thing. And that's mitigated by culture and values and opportunity and a lot of things. But the fantasy is there.
It's not a marginal fantasy.
It's not a marginal fantasy at all. And the third most common fantasy is actually bondage, dominance, and rough sex. When people say, ooh, so those are other people, those are on the margins. So my hopefulness is from the conference as well, and from my student, is that we persist, is that people are doing this work. And to me, working in human sexuality is social justice. The two are not separate. You cannot separate the two. The two are about equal rights, about access to healthcare, reproductive rights. There's nothing it doesn't touch on, but you cannot separate them. So, my areas, within our institution of diversity and around sexuality and gender stuff, I see it all as the same thing. Social justice, it's all the same thing. And the people there that are doing this research and are fighting to keep their funding and are finding other ways to get support to continue this research has been very inspiring.
Yeah.
So they give me hope.
I appreciate that. I agree. One of the things that makes me hopeful, and I know this may come across as a little biased because we're both with the Chicago School, but it makes me hopeful that we have faculty like you, Dr. Berkey, and the program there in Chicago who've made this a priority for the training of future psychologists. And I think that's what it's going to take. We just need more programs integrating this content in the curriculum. And then there's this critical mass of,
Yeah.
highly qualified doctoral mental health professionals out there with the competence, with the knowledge, the skills, and the attitudes to do right by
The,
clients.
the people that are doing the supervision and training, as well as the clinical work. And, I don't know that this is hope, but it's an exciting piece for me. As we're opening the College of Osteopathic Medicine here in Chicago,
Yeah.
I am very excited about the opportunities for interdisciplinary practice and have started talking to the psychiatrists teaching in that program about where we're going to get sex into the medical school because physicians not any better than us when it comes to
Yeah.
sex. They might be able
Unfortunately.
to tell you if you got an STD or a reproductive issue, but if you try telling them about problems with orgasm or pleasure or alternative ways to have sexual pleasure because you are a quadriplegic or you do have diabetes, can't help you.
Yeah,
So
no
this
training.
is my mission grows to now really integrate this across our programs.
I love that, and I'm very excited about the opportunities with the College of
Yeah,
Osteopathic Medicine as well. Well, Dr. Berkey, if I know we're close to the hour, but do you have some time to take a few questions?
sure, absolutely.
All right, everyone, it is your turn. We'd love to hear some of the questions that have come up for you as Dr. Berkey and I have talked this evening. You can either pop on camera and ask your question or drop it in the chat.
Hi, my name is Fatima. I am a graduate student at St. Cloud State University last year of master's and doing my internship at Centra Care. I'm actually a new applicant for Chicago School, so this is my first event here. Dr. Berkey, I really want to thank you for this courageous, how can I say, like courageous initiative, and I am actually an international student. So I was psychologist in my home country for 5 years. I'm from conservative society.
Mhm.
So there, I was struggling with when I talk about sex, I was like considered as like inappropriate. And when I came
Yeah.
here, it was a very big move and cultural shock. And then also when I started my career here as an intern, I still like 2 years only in USA. And I found out that also people, which is clients, looking at me like you don't fit, you know? So I was not fitting in there because I
Mhm.
was having this background, and here I am not fitting in too to talk about it.
Yeah.
So how can the clinician deal with the client racism? Sometimes the client is
Mhm.
racist against the clinician.
Yeah. Yeah.
Thank you.
So are you just sharing that, or is there a
Yeah,
particular
I
question?
I was sharing the situations because like now I'm like,
Yeah.
you know, I have this, like, I was in a conservative society and I was trying to teach
Yeah.
people how to like healthy sexual life. So clients
Mhm.
were like shocked and describe me like inappropriate in my,
Yeah.
according to my community as a woman. You shouldn't know anything about it.
Yeah.
Okay. So now when I came here, I know little, very little.
Mhm.
So I have some study during my master's
Yeah.
degree, and I should graduate next May from my master's. And so I have also the feeling that my clients look at me and see like, you don't understand what I'm talking about. You know, I
Yeah.
understand I am accepting you, but you don't accept me. The client sometimes doesn't accept the clinician. Do you understand myself?
I'll absolutely understand it, and that can happen in so many different ways, and that in and of itself is worthy of one of these sessions to just talk about that in and of itself. My short response to that would be if this is becoming the issue in the therapy room, then it needs to be addressed just very head on. You know, it's no if someone keeps raising something about your ethnicity or, your culture, at some point, I'm just gonna kinda lean back and I realize you bring this up almost every time we meet, and I wonder, you know, why you bring this up every time, and it's clearly an important part of our relationship, and we need to take a look at that, and there's an awful lot more to that process than that simple statement. But I just think, it is a courageous thing to bring it into the room.
Yeah.
And I do think, it's not confronting the client, it's just recognizing that this clearly, and you know what? Maybe they'll be able to talk to you. Every client's different, it's gonna be a different situation. But maybe they are able to talk to you and say, "Yeah, I've had this experience," or I grew up thinking this about people who I think are from your country." And, like, some of it's just having that, like, humanizing conversation. And it's hard. It's really hard, and you have to take care of yourself, and I hope you have good supervision that where you can go and process this, but it's God bless, it's a really difficult process, and we can't run from it, and a lot of times I'll hear students just say, or other clinicians say, "I'll just refer them," and I'm like, "This is not how we create change in the world." This is not how we create change in the world.
That's what I mean. When you open it and they try to talk about it, sometimes they refuse us, like us as a clinician, or judge us as a clinician.
Yeah.
But
And there is a point where if it just becomes unworkable, you've done everything in your power to try to make space for this, to say, do you think you would work better with somebody else? There does come a point for that, but that's not where we start. That is not where we start.
thank you.
Yeah. Good luck
Thank you.
with it.
Yeah. I believe Brianna had a question next.
Yes. Hi, good evening, everyone. I'm not at home, so please excuse the background noise. I am on the busy streets of New York City right now. Um, but good evening, everyone. Thank you, Dr. Berkey, for this great conversation. I am really interested in forensic psychology, so I wanted to know your perspective on working with clients who have sexual trauma, but you are also trying to cultivate that safe environment for them to speak of it.
Yeah. For me, the trauma thing, it's all about creating that safe space. Invitations to talk about things, but not moving faster than the client. There are times when I think we do need to move a little ahead of the client and kind of that's not one. That is not one at all. And I really, I've worked in lots of different settings, and some of them were time limited. And those issues are not short term work. It's a lot of your first year or two or three, maybe just building the relationship with somebody. That's my experience with it.
Thank you so much. Yeah, I really am just very intrigued on how we as future clinicians try to work with these populations without intruding, without
Yeah.
maybe triggering the clients. You are there to help, but you also don't want to
Yeah.
make the client uncomfortable.
Yeah. Well, I mean, part of that with all that is building responses in the client and giving them tools before you even get there. So how do they self-soothe? How do they ground themselves when they get into these things? And I'll say this kind of very, very related to our conversation thus far, is that it's not those people out there. We have a lot of people in our school and a lot of people in our profession who have experienced sexual trauma. And I would say that's another thing that we didn't touch on, that I have had conversations over the years with different campus leads or chairs or what. How can we address this very openly about there are wounded healers, and being a wounded healer is not a bad thing. You can be an amazing clinician if you do your own work. And so, not making space for students where they, in an appropriate way with appropriate boundaries, be able to say, as a clinician, I've had this experience. What do I do when someone starts talking about that? And how do I handle triggering? How do I do that? Like, a lot of that's your therapy, but we really fail our students when we do not train them about, very much like the other lady before, about how do we talk to them about these very difficult triggering things that happen when we engage clients, whether it's around our identity or shared traumas. We need to do better.
Yes, absolutely. Thank you so much. That was very insightful. You want to do your best to show up for the client while also acknowledging your own limitations.
Yeah,
Thank you guys so much.
sure.
Thank you, Brianna. I think I saw one more person jump on just before Brianna with a potential question. Neil.
Yes, that was me. Hi, everyone. Thank you so much for this talk. This was very, very eye-opening and enlightening. And the question that I had was related to, more specifically, children and adolescents. And that's a space that I've been working the past few years and what I'm most familiar with. And recently, I started at a psychiatric hospital working an inpatient unit down here at Vanderbilt, and got to see them more, I guess, for more time, and also kind of seeing them in their subgroups as they have those recess and break times. And one thing that I notice a lot is that the concept of gender identity orientation seems to almost have a negative rhetoric with the younger demographic. I'm not too sure if that's coming from influence, whether that's coming from a place of not wanting to be different or necessarily stand out. But my question is, how exactly do you go about, quote unquote, managing or controlling that rhetoric so that it doesn't kind of foster a personality trait that they carry for the rest of their life? And that's an aspect that, they kind of bridge with other people that they're coming in contact with, especially at that naive and young age. Is there anything that you would recommend or that you tend to do in those situations? Or is it more of just having them learn through the experiences of growing up in environments where people are going to be different and have different backgrounds and different orientation and identity and things of that nature?
So when you say rhetoric, it's sort of something you're picking up on, a culture amongst the youth in your program. Like the thing that's still very popular, say, "Oh, that's so gay," is a slur.
Yeah.
I think it's like anything else. Part of what I would hope would happen in programs is empathy building. and just like say someone, we don't know who's in this room. We don't know. We don't know their identities. Like how, if that were you, how would that feel? What would that be like for you? I think there, especially in young men, uh, especially in young men, there is a very strong push to reject, diversity in terms of gender and sexuality. And it's protective because developmentally, many people go through phases of same-sex attraction. It doesn't mean they're gay or bisexual or anything else. It's just part of development, and it's frightening given the culture we live in. So they push hard against it. And so, the more you can just sort of normalize, like, we have everybody here. We have everybody at this place. What is, let's talk about that. If it's a recurring theme, just like we were saying earlier, if it's a recurring theme, it's a great conversation to have in group therapy. You're like, what is this about? Like, what does it mean to be which we do not do very well at all as a society or as a clinical culture. It's like, what does it mean to be male? And that then you have to get into the cultural components of that and the SES components of that. What does it mean to you to be male? Because people, the toxic masculinity is a real thing. I think the term gets thrown around a little lightly sometimes, but being hyper masculine and being so defended that people do damage to other people. And I think a lot of the hate crimes are conducted by people because of their own internal issues. So I ask them where they're getting it. Like, where'd you pick up that term? Or where did you come from? Yeah, it's a very gentle jujitsu.
But yeah, I haven't heard that.
Hey, that's rude. That's not woke. That's rude. And by the way, woke, and I got to quote Jane Fonda, woke just means you care about other people. I think she said it a little differently, but woke is a good word. So just not weaponizing that someone's maybe not as far along in their own development and empathy, but, just kind of meeting them where they're at and asking them, well, where'd that come from? Wonder why that is. How do you feel when you say that? That's a pretty good question. When you say that to someone, do you feel, are you fear, anger? You feel more masculine? Do you feel powerful? What's the feeling that goes with that? Those slurs.
Interesting. So more so get them to introspect of why exactly they're even behaving or saying these things in the first place, rather than kind of pinpointing that, hey, this isn't necessarily the right way to go about it or the right thing to say.
Yeah. Again, shame does not change anybody. Shaming people does not work. And it's back to our prior points about how do you create an affirming environment. So in your facility, are there ground rules for the thing about how we use pronouns and how we talk about people's sexuality? Those are always good. I think you're setting a culture when people come into a residential or inpatient or intensive outpatient. But also, I always want to sit down with the group and say, okay, this is what the facility says. What are the rules we want? What rules are we creating here? Because they're youth. They're gonna break the rules, And what are you gonna do? Punish them because they said something? They called someone a name. That's not a good message. We don't want people to treat other people with respect because we punish them into doing it. We want them to do it because it's the right thing to do and because it's their value.
Thank you so much. I honestly I didn't look at it from that perspective, and I think that's very helpful.
Well, glad I can help.
All right. Thank you, everyone. I appreciate your time this evening. Dr. Berkey, especially you, thank you so much for joining us. I really enjoyed the time with you.
Always, always, always. This is why this is my professional mission. So I'm happy to have any opportunity to talk with other folks about it. So thank you for the opportunity.
Definitely. It was my pleasure. And for everyone who joined us, thank you so much for joining us this evening on Perspectives in Professional Psychology. We'll see you again in January. Bye, everyone.